Welcome back to the deep dive. If you're getting ready for IVF, you probably know it's not always a straight path.
Not at all. It often feels more like, well, navigating a complex biological puzzle, right?
Exactly. And today we're digging into some common twists and turns, dealing with ovarian challenges like poor response or finding endometriosis or maybe even unexpected cysts.
That puzzle analogy is spot on because the answers aren't usually simple. They have to be really personalized.
Yeah.
So our goal today is basically to unpack the kinds of tests and tailored plans doctors use when the ovaries present these unique challenges.
Because getting news like you have diminished ovarian reserve or, seeing a chocolate cyst on an ultrasound scan, it can feel pretty overwhelming fast.
Absolutely. It can be scary.
But the reality is successful IVF, especially when things are complex, hinges on understanding the science behind it all, customizing the treatment.
That's the key. Customization.
So we're aiming to bring some clarity to that today, starting right at the foundation.
Yeah.
Figuring out your ovarian reserve. What are we actually working with?
Exactly right. The first thing, the non-negotiable step in any IVF plan, is really getting a handle on ovarian reserve.
Okay.
It's the specialist's best guess at your egg quantity, your remaining egg supply, and sort of indirectly, the general quality too.
And that number dictates a lot, doesn't it?
It dictates almost everything, the potential for success, and really critically, how much medication, what kind of protocol is needed.
So hormones are key here. Let's start with AMH, anti-Mullerian hormone. Everyone seems to talk about AMH first. How do we interpret that?
Think of AMH as like the inventory count. It's made by the small follicles growing in the ovaries.
Okay.
And the great thing about AMH is that its levels are pretty stable. They don't fluctuate wildly through the menstrual cycle.
Which makes it reliable.
Very reliable. So a low AMH points towards diminished ovarian reserve, or DOR. And knowing that is absolutely vital for figuring out the dose of fertility meds, the gonadotropins we need to use.
Got it. AMH is the inventory. So if the inventory is low, the body might be trying harder. Is that where FSH comes in? Follicle-stimulating hormone, you called it the effort signal.
Precisely. That's a good way to put it. FSH is measured really early in the cycle, usually day 2 or 3.
Right at the beginning.
Yes. And if the body is, let's say, struggling to get good follicles going, the pituitary gland ramps up FSH production to try and compensate.
Ah, okay.
So a high FSH level tells us the ovarian function might be reduced. The body's pushing harder because the pool of eggs is maybe smaller or less responsive.
And then during the actual stimulation part of IVF, you track estradiol, E2. That's like the real-time check.
It really is. Rising E2 levels, that's the story of the cycle unfolding. It shows us the follicles are growing, maturing, responding to the meds.
So it confirms the plan is working.
Exactly.
Yep.
It tells us the protocol is doing what we hoped it would.
Okay, moving from the blood tests to what you can actually see. The ultrasound. How critical is that transvaginal ultrasound early on?
Oh, it's crucial. The goal there is to get a physical count, the antral follicle count, or AFC.
Antral follicles. Those are the small ones.
Yes, the tiny visible follicles, usually 2 to 10 millimeters, that are basically ready and waiting, potentially available for stimulation in that cycle.
So a higher number is better.
Generally, yes. A good AFC suggests a healthy pool of eggs and predicts, a more robust response to the medication.
So we're not necessarily focused on exact sizes here, just that there's a decent group of them.
That's the main thing. A good cluster, a strong AFC, predicts a better outcome.
I've heard about 3D ultrasound being used more now, too.
Yes, absolutely. And there's a reason for that. 3D gives you not just a flat image, but a volumetric view, like a model.
Okay. More depth.
Right. Which allows for a much more accurate count of those antral follicles. And it's also better at spotting any subtle structural things that might be going on compared to standard 2D.
Okay, so we've talked about assessing the reserve, especially when it might be low. But what about when the ovaries function itself is the main issue? Let's start with PCOS, polycystic ovary syndrome.
Right. PCOS is often described as, hormonal chaos. It's a very common endocrine issue.
What defines it?
It's usually characterized by having excess androgens, male hormones, often linked with insulin resistance, and that typically leads to irregular periods, or sometimes no periods at all, no ovulation.
A major cause of infertility, then.
One of the leading causes, definitely.
And it has that very distinct look on ultrasound, doesn't it? The string of pearls.
It does. Often the ovaries look a bit enlarged, and you see lots of small follicles, maybe 12 or more, lined up right under the surface. It gives that classic pattern.
So the IVF challenge here isn't too few eggs, it's almost the opposite.
Exactly. It's paradoxical. These patients are often high responders, they have plenty of follicles, but their system is incredibly sensitive to the stimulation drugs.
So the medication strategy must be totally different from someone with low reserve,
Completely different. It's a real balancing act. The big risk with PCOS is ovarian hyperstimulation syndrome, OHSS.
which can be serious.
It can be quite serious, yes. So the IVF protocols have to be super precise. We use much lower doses of the gonadotropins, those stimulation meds,
Lower doses.
and we heavily rely on specific types of protocols, often called antagonist protocols, which are designed to put the brakes on, control that potentially explosive response, and really minimize that OHSS risk.
Okay, now let's flip to the other end of the spectrum. Premature ovarian insufficiency, or POI. That sounds quite tough.
It is. It's essentially early ovarian decline. POI is when the ovaries stop working normally before a woman turns 40.
And hormonally, that looks like.
You see that low AMH we talked about,
Yeah.
combined with a high FSH? It's a significant, often rapid drop in both egg quantity and quality.
And the causes are interesting. It's not just about aging faster, right?
Ah.
Sometimes it's systemic.
That's right. A lot of cases we don't know the exact cause, they're idiopathic, but POI is often linked to autoimmune conditions.
Like the body attacking itself.
Yes, where the immune system mistakenly targets and damages the ovarian tissue. And importantly, it's also linked to certain genetic factors.
Guess one stand out.
The most well-known is the Fragile X premutation. Our sources suggest that maybe 20, even 25% of women who carry that premutation might develop POI.
Wow. That really highlights why genetic screening can be important sometimes. So if this decline happens early and it's often irreversible, what's the main strategy for IVF?
Well, if POI is caught very, very early, sometimes fertility preservation, like egg freezing, might be an option to try and save some eggs before the reserve is totally gone.
But if it's further along?
In cases where the reserve is severely depleted, the most effective path forward is usually egg donation. It offers very high success rates for patients facing POI.
Okay, let's shift gears a bit now to structural things.
Yeah.
Physical issues within or around the ovary.
Mm.
We have to talk about cysts first, because not all cysts are bad news, right?
That's such an important point. Most cysts that pop up are actually functional. They're just part of the normal monthly cycle.
Like what?
Like follicular cysts, which held the egg, or corpus luteum cysts, which form after ovulation. These usually disappear on their own within a cycle or two. Generally, not a worry for IVF.
But then there are the ones that do cause problems, like endometriomas. People often call those chocolate cysts.
Yes, endometriomas are cysts caused by endometriosis. That's when tissue similar to the uterine lining grows outside the uterus, like on the ovary.
And they're called chocolate cysts because
They fill up with old, dark, brownish blood, giving them that appearance, and their impact can be quite significant.
how so?
Well, the presence of that endometrial tissue causes chronic inflammation right there on the ovary. That inflammation can actually damage the healthy ovarian tissue nearby and potentially compromise the quality of the eggs within it. So it can definitely affect IVF outcomes.
Is there a blood test that can hint at endometriosis? I know diagnosis is tricky.
There is a marker, CA-125. It can be elevated with endometriosis, often due to the inflammation.
But it's not definitive.
No, not at all. It's not specific enough on its own. Lots of other benign things can raise CA-125 levels, so specialists might use it as one piece of the puzzle, alongside the ultrasound findings and the patient's symptoms, but never as a standalone diagnosis.
So when you do have these structural problems, maybe large endometriomas or scar tissue, adhesion surgery often comes into play. Laparoscopy.
That's right. Laparoscopy is the common approach. It's minimally invasive, uses small incisions, and a camera keyhole surgery.
And the goal is?
The goal is to diagnose for sure, and then to correct the problem surgically. So removing those problematic endometriomas, cutting away adhesions or scar tissue, sometimes even performing ovarian drilling in very specific cases of severe PCOS, basically to try and create a healthier environment for conception.
But there's a huge catch with operating on the ovary, isn't there? This idea of fertility-sparing techniques.
This is absolutely critical, the central challenge, you could say.
Why is it so delicate?
Because every ovary has a finite number of eggs stored in the outer layer, the cortex. Any surgery on the ovary carries a risk of unintentionally removing or damaging that healthy cortex, along with the cyst or scar tissue.
Which would reduce the egg reserve further.
Exactly. It could deplete the very reserve we're trying to work with. So the surgeon needs incredible skill to carefully peel away just the cyst lining, for example, or remove only the damaged tissue while preserving as much healthy egg-bearing tissue as possible.
That balance sounds incredibly difficult.
It is, and getting that balance right often makes a huge difference to whether subsequent IVF is successful.
Okay, so this whole deep dive, it's been about gathering all this information, hormone levels, AFC counts, checking for cysts, PCOS, genetic factors. How does a specialist put all these puzzle pieces together for the final treatment plan?
That synthesis, putting it all together, is what leads to optimizing the stimulation protocol.
Meaning the medication plan.
Precisely. Based on that whole picture, the AMH, the AFC, whether someone seems to be a low responder or maybe has PCOS and is a high responder risk, the dose of gonadotropins is meticulously tailored
Tailored for what outcome?
to get the best possible number of good quality eggs while being really careful to avoid complications. So, avoiding OHSS in high responders or trying to maximize the yield, however small, for the low responders.
And speaking of those low responders, people with diminished ovarian reserve. There are some pretty advanced strategies now, aren't there? Things we didn't have just a few years ago.
Absolutely. We're learning more about ovarian biology all the time. One of the cutting-edge protocols for this group is called DuoStim.
Duostim, double stimulation.
Exactly. The thinking behind it comes from realizing that ovaries don't just recruit one wave of follicles per cycle. There seem to be multiple waves.
Oh, interesting.
So DuoStim basically involves doing 2 separate rounds of stimulation and 2 egg retrievals back-to-back within a single extended menstrual cycle.
Why do that?
The goal is to collect more eggs in a shorter amount of time, really maximizing the opportunity for those patients who have very limited reserves to begin with.
We also hear a lot about supplements. People trying things like CoQ10 to boost egg health. What's the real story there?
Yeah, coenzyme Q10 or CoQ10 is probably the most talked about. The idea is that it might help support the mitochondria, the energy centers within the egg cells.
Does it work?
Well, it's being studied. There's some research suggesting potential benefits for egg quality. But the really crucial thing to understand is this. Supplements might, maybe, support the quality of the eggs you already have.
But they can't make more eggs.
Exactly. They cannot reverse low egg numbers. They can't increase the total ovarian reserve you were born with. That's a really important distinction.
Okay. Finally, let's circle back to genetics. Given what you said about POI and Fragile X, genetic testing of the embryos themselves seems like it could be really valuable for some people.
It is incredibly valuable in certain situations. Pre-implantation genetic testing, or PGT.
What can it tell you?
There are different types. PGTA screens embryos for aneuploidy, which means having the wrong number of chromosomes. This is particularly helpful for older women as chromosome errors increase with age.
In PGTM.
PGTM screens for specific single-gene inherited disorders, like the Fragile X mutation we discussed, or cystic fibrosis, or others if there's a known family risk.
So by choosing the genetically healthiest embryos,
By selecting the embryos that are chromosomally normal and free of a specific known disorder, we significantly increase the chances of a successful implantation and, ultimately, a healthy pregnancy, even when the starting point is complex. #tagoutro.
So if we sort of zoom out from all the technical details, the big message here seems to be that complexity in IVF, especially around the ovaries, doesn't mean it's hopeless. It just means the approach needs to be really customized.
That's exactly it. Managing these ovarian complications successfully is all about using the best diagnostic tools we have, AMH, 3D ultrasound, maybe genetic screening, to build a truly unique, personalized treatment plan for each individual.
So the key takeaway for anyone listening who might be facing this.
I'd say the most important thing is getting that early, thorough, personalized evaluation. Really defining what specific challenges or constraints you might be working with right from the start.
Makes sense.
And it's worth remembering, too, that complexity often goes beyond just the ovaries. Think about autoimmune disorders. For example, things like Hashimoto's thyroiditis or lupus. These affect women much more often than men.
And they can impact fertility.
Yes, the immune system can sometimes mistakenly attack ovarian tissue. So managing these systemic conditions might require specialized care that goes beyond just the standard fertility treatments. It really shows how interconnected everything in the body is.
That's a really profound point about the bigger picture of reproductive health. Now, just a reminder, this discussion has been purely educational and for informational purposes only.
That's right.
It does not constitute professional medical advice. For specific medical advice, you absolutely must consult a qualified doctor.
Please do.
And if you'd like more information about the complete IVF process, you can find that at ivfforme.com.